All right. All right. Hey, everybody. This is Eric with Motion Guidance. Welcome back for this week's Zoom interview. We have Dr. Erson Religioso with us. You might know him from modern manual therapy courses, and he also is the owner of Edge Rehab and Sport. So, Erson, why don't I just, what's that?
It's Edge Rehab and Sports Science.
Oh, sports science. All right.
Yeah.
Got to get the full name in there. So let me turn it over to you. Why don't you give yourself the full intro for our audience today?
Hey guys, I go by Dr. E online, but if you ever hang out with me or talk to me online, which there's many different ways to get a hold of me, I'm at Modern Manual Therapy on Facebook, Instagram, and YouTube. I'm also on LinkedIn under my name, Erson Religioso. My other brands are Edge Mobility System, which is my e-commerce store. Check that out. It has all my live Eclectic Approach courses. Another one of my brands, the Eclectic Approach. I originally started that with modern manual therapy, and then I also have modern strength training, which is a BFR course, modern patient education, where you learn all the soft skills that you don't learn in school, like sleep and recovery and breathing and pain science education and mindfulness. And now we also have modern nutritional rehab, which is a fully certificate course for nutrition for physical therapists and rehab-based clinicians. So that's all approved in almost every state in the US now. So head over to edgemobilitysystem.com or theeclecticapproach.com. And I also host a podcast called Untold Physio Stories with a lot of wins and losses. And just it's perfect for a commute. It's like 5 to 10 minute mini cases. So I've been using motion guidance in my practice, my cash-based practice in Buffalo, New York, which is Edge Rehab and Sports Science, for probably over 10 years now. And that's one of my favorite products, which is why I also sell it on my Edge Mobility System. So thanks for having me, Eric.
Yeah, great. I'm glad you could make some time for us. How's the weather during winter over there in Buffalo?
You know, last year we had like an old school Buffalo winter. There was so much snow, like what we're known for, like multiple feet of snow. Almost the entire winter we had snow, but due to climate change or whatever, I mean, we have like really mild winters now. Even if we get a foot of snow, it melts in like a couple days. So last year was great because, you know, right before that, I was just telling my wife, like, I don't know if our kids are ever going to get, like, they get excited when there's like a dusting of snow and you can still see the grass, you know? We had a brown and muddy Christmas recently. It's really mild again, but today's my daughter's birthday, or her 13th birthday, and it actually snowed like 4 or 5 inches. So yeah, that's good. We have a white birthday right now, and we're supposed to get a couple more inches, but they were calling for like a foot and a half, so it was pretty disappointing.
Okay.
That it wasn't a foot and a half.
That's one of my favorite holiday songs since we just got over the holidays is A Brown and Muddy Christmas. I forget who the author was, but that's a big one. I have that on my playlist.
It was me and my dogs is what it is. This is like the time of year when my wife wants to give away the dogs.
Oh, sure. Tracking everything through the house. So yeah, we've done some collaborative things for numerous years now, and we've worked together. What is it that you really like or appreciate about having the motion guidance system in your practice, and maybe some of your clientele? What do they give you feedback on when they order the system through your platform?
Well, I think everyone likes to kind of gamify or, in a way, like objectify motion, right? So if my current system has kind of plateaued and, you know, I find that repeated end range loading resets or any of my kind of manual therapy tips and tricks restore pain, but they don't necessarily restore motor control, it's just a much easier way for a patient to kind of realize extrinsically how well they're doing with their strength or stability. You know, I worked in the past with a lot of up to elite gymnasts and a bunch of just, you know, teenage gymnasts. And one of their favorite sayings was a gymnast can do anything but walk, which is crazy because, you know, we're talking about people who can like spin around on their toes on a balance beam, do forward and back flips on a balance beam, and yet when they injure a knee, and it's a unilateral problem because they never do any kind of unilateral training, they have the worst stability. And, you know, I don't really do a lot of baseline training or baseline stability testing on them, but I have taught a lot of the coaches I work with. just like simple movement screens to check for asymmetries, but not stability screens. And it just always astounds me at how adept they are and how strong they are and how fit they are and how poor their motor control can be. So, I love using the motion guidance like around their knee and then with like either a big line or the grid, and just even having them do like, starting with squats and then progressing to lunges and then progressing to mini single limb squats, just to improve their stability. I don't tell them that they have to be an exact a straight line, but I mean, try to minimize that left to right as much as possible. And again, I think most people really just like it because it just gives them visual feedback, and it's much better than the mirror feedback, or like, because a mirror might be far away, or it might be like the weird perspective that you get from those tall mirrors that people have in their rooms that always seem to be like a funhouse mirror to me. Um, they have some kind of weird like perspective to them, right?
Right. Yeah.
Also makes you look thinner than you are or
Yeah.
something.
Yeah. Yeah, got to look down at them, and if those things
Right.
fall over, that can cause some damage to you or a local pet. So you got to be, gotta be
Yes.
careful with those.
Right. Yeah. So, I mean, I've always appreciated that. I have an old school one. I think you guys have all different kinds of colors now. I still have like red lasers.
Yeah, we got the green rechargeables, and we changed our branding colors a little bit, and made them a little
Yeah,
bit
I'm
more
partial to blue.
fun. Yeah, yeah, yeah. Maybe we borrowed that a little bit.
Yeah.
No, we didn't. No, I
Yeah.
think
See,
you're
this is like
touching on.
my logo, but it's like done in the style of the Steve Rogers shield.
Right, right. Yeah,
Yeah,
you finish it off, and it's you feel like a superpower a little bit.
I
Yeah.
do. Yeah, it's just like my superpower shirt,
I,
Captain E.
That's right. I think you're touching on something there. Regardless of level of expertise in anything movement based, whether that's obviously included in certain types of sports or certain types of maybe work, there has always been a sign of certain people with different types of injury need some reintegration that they might not be able to feel because they're so used to doing it at an elite level, sometimes very similar to a novice level, in the sense of, well, I don't really know what I'm doing. And obviously they pick up on those things a lot faster because they've gone through so many thousands of repetitions to do it. But providing some type of visual feedback in real time can allow them to integrate what's going on, and obviously they process those things a lot faster typically, and you don't need to spend much time there. But yeah, we always like to hear when people are using the system for not just novice learners, but even for, hey, I'm trying to get back to the level that I was, and I got a little hiccup here, and I guess I didn't realize that my left side was moving completely different than my right side. Or when I was trying to stare down that ball coming out of the hand of the pitcher, I didn't realize I was dropping my chin a little bit, where I used to maybe never do that. And it's an inexpensive way to get all that information going for a variety of different clients. So that's always great to hear.
Yeah.
In
I would
those,
also say before,
yeah,
I'm sorry to interrupt you. That before this, I think I would make the mistake that a lot of PTs and probably a lot of coaches make, is using too much verbal cueing, and you just assume that the more verbal cueing, the better. And I've learned in a lot of the stuff that webinars that you've done for my modern manual therapy group, MMT Insiders, that the less verbal cueing, the better. That the simpler it is, the better. Because
right.
people do better with like minimal amounts of queuing, not like, I mean, no one ever wants like 30 cues. Hey, you're doing this, 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 and this.
Yeah, it is
That's
kind of
what we see
interesting.
as
Yeah.
movement clinicians. Yeah.
Yeah, you get in the clinic and all of a sudden you're like, well, I want to give them all the knowledge that I feel like they need. And the learning models really suggest small pieces dripped over time, and then giving them a lot of their own, intrinsic input will, help them along a little bit easier. And we tie into that auditory system far too frequently when we're trying to give people a learning experience. And that's the least preferred learning style for people out there, which also kind of challenges, I think, a lot of our instructors as we came up with school. We're getting a lot of auditory
I know, right?
feedback.
It's like 100% auditory as you're
Yeah.
in school, right? Yeah.
It's like, okay, so now that I've said all these things for 45 minutes, I've hoped you've learned something. And
Right. Yeah.
Yeah, that's I think all of our favorite teachers, there was something that tied into us personally when we got that, that said, hey, they allowed me to do this, or I got my hands on it, or I got to see it as well as hear it. And there's something dynamic with integrating learning models versus just the talking to you for a long time. Or, hey, I have you in a position where you can't see your body, but can you feel this when you're, moving your
Yeah.
pelvis like this?
Right.
Like,
Right.
yeah, sure I can. I have no idea what's going on, and you're standing behind me. So yeah, integrating those learning models, giving everybody the option to have kinesthetic, auditory, and visual, and maybe not all at once, and maybe not consistently over their training or their learning, can really develop that optimal input. But you integrate a lot of that stuff into your classes. What were the modern manual therapy links again that you can send people to?
Yeah, if you go to theeclecticapproach.com, that lists all my current courses.
That's right.
But overall, edgemobilitysystem.com has all my products, like all my ISTM tools, my blood flow restriction stuff, edge restriction system, and also all my courses. So, my flagship course is Modern Manual Therapy, the Eclectic Approach to Upper and Lower Quarter Assessment and Treatment, to kind of go over, my version of manual therapy, which, I'm a classically trained manual therapy fellow. I've probably have learned 300 different ways to passively assess that are all garbage. And so my whole thing is manual therapy can be done by anyone. You don't need like 8 levels of minutia of pressing and guessing or poking and hoping. And I think even if, like me, and I've been doing this 23 years now, you trained to believe that you can feel the minutia of a facet gapping 1 millimeter, and one immediately adjacent to that is 2 millimeters, and you eventually believe that you could feel the difference. It turns out you don't need to believe all that stuff, and you really just need to get people moving. You need to put a positive spin on everything. You need to de-emphasize palpation. Every technique, similar to Mulligan, can be 100% pain-free, which I definitely didn't learn. I used to teach, even in my early manual therapy courses, that if you don't break up the fascia and the adhesions and you're not aggressive enough, you don't bruise a patient by the end of the first week, then you're not being aggressive enough. So I used to literally bruise everyone, palpate everything, manipulate everything 500 times. And now I try to use as little manual therapy as possible, put an emphasis on completely pain-free, repeated end range loading resets, very similar to like a McKenzie-like approach, combine it with a lot of stuff I learned from Mulligan and David Butler and Institute of Physical Art, a lot of PNF, but I kind of put all that all together along with a ton of other courses that I took for the first 5 years of my career. And I turned it into the eclectic approach, and that's why I call it eclectic, because, the best practitioners don't just kind of hold on to one kind of guru or one school of thought. They pick and work whatever is best for them. And it turns out that everything really works for the same reason. There's no real different mechanisms behind repeated end range loading, mobilization, manipulation, soft tissue work, and dry needling. They all work for the same reason. They're all just novel input to the central nervous system, that in the central nervous system can make one of two judgments, it can say this is a red light or a green light, and it does the same thing with positions, activities, or movements. So, if you present something as novel and you're really slick at selling it, and you've taken a lot of courses in it, it might be why you have better outcomes with needling rather than mobilization. Maybe you just couldn't sell it or explain it well, or maybe your hands, didn't translate to a certain type of technique, but it has nothing to do with that technique's particular efficacy. So again, it's my way of like just modernizing the mechanisms behind everything, then also how to give patients kind of the best bang for buck, because it's all about the home program and also all about changing their beliefs and their maladaptive beliefs in particular about themselves, their body image, their movements, and in particular positions, and what I call like thought viruses, or again, maladaptive beliefs like bending forward is bad for you. Sitting posture is related to pain, and it's not. I do tell them that the best position is an X position, so you should get up and move regularly, but you don't need to sit like ramrod straight with a lumbar roll, which is how I told everyone to sit. I sold a ton of lumbar rolls in the first 10 years of my practice, but I don't do that stuff anymore. I barely correct posture, and I'm getting better results than ever because I make it all on the patient and less on me. First 10 years of my career, it was all about me, how awesome my hands were, and I'm going to fix you. Now it's all about changing patients' behavior, their view about themselves, and giving them the tools, which I call a recovery plan and not a home exercise program, to get better. And many times that does include the motion guidance, especially when my resets and the stuff that I normally teach them kind of plateau.
Sure. You said a whole wonderfulness there about numerous different things. Yeah, but it's all super relevant. I mean, you touched on so many things, and I think we have to touch on so many things because that's what's required when we're, as clinicians, we treat humans, right? That's how I typically put it in my classes that I'm instructing, and even in my clinic. It's like, well, yeah, we can say we want to treat Dr. E, we want to treat Lily down the street, we want to do whatever we want to do, but actually putting that into the practice can be a little bit difficult when you're like, well, I'm trying to treat the person that's in front of me, because all the things, if I summarize what you said, we're always just looking for responders. You can find a lot of responders to a lot of the same techniques, but you're also going to find some people who just don't work with that well, or they're not improving. So if I might pose a new question, what do you think some of the major challenges are for clinicians, whether they're in, neurophys, whether they're in orthopedics, pediatrics? What do you think some of the big challenges are for clinicians just to start getting some results? And if I might put a caveat on that, when I search social media and I interact in social media, sometimes I notice a trend of certain clinicians going too hands off and expecting no change over time. It's more like, well, I'm just going to give in to natural history progression, and this is going to take months. Sometimes I see and be like, oh, I'm just glad to be coaching people through their dysfunction over the next 3 to 6 months. Right. And it just, I halfway cringe, because that pendulum is swinging from people like you and I, who are like, well, we're always looking for like, what can I do right today? And then, oh, this is going to take 6 months, and it's probably somewhere in the middle. But I think a mindset of trying to make immediate changes for the improvement of the patient, whether that's a variety of mechanisms, a psychological thing, an actual true range of motion, or a pain thing. Why do you think that we have such a challenge in our profession to do that?
Well, like you said, I think the pendulum is swinging a bit too far. At this point, it is very much, kind of started with pain science, and then it very rapidly became pain science is also not good enough, and I don't want to just talk to people only. And now it's only like, I'm only going to look at movements, and I'm I'm a strength coach only. Like I'm a strength coach first and a PT second, and I get it. I mean, because literally strengthening, and not just exercise. A lot of people just say exercise, but really strengthening, even in of itself, when it's done well with actual like good principles and good programming, is probably one of the only evidence-based treatments that is good for every condition known to man. Like, you could be dying and you should still do strengthening. You could have cancer, you should still do strengthening. No matter what, it never hurts to do strengthening. But yes, you take this too far and you say all manual therapy is placebo. Sure, I wouldn't say all manual therapy is placebo. I would say it's definitely non-specific effects, and whatever. Just because it's non-specific effects doesn't mean you can't get rapid results with it. And I always just think, I guess one example I should put it really quickly. One of my fellowship mentees, who eventually ended up studying, ended up doing research under Joel Bielowski, who, if you've never read any of his research, amazing researcher who basically upended manual therapy and really got me away from like a mechanistic pathoanatomical mindset to everything is neurophysiologic and non-specific, and we don't really know why it works. We just know that it works, and that it works rapidly when it works, and then you just get someone to move it, open up a window of improvement, and then you can get them loading, strengthening, doing motor control, whatever. So it is very good for rapid pain relief and rapid movement improvement, but it is still up to the patient, no matter what, to keep that. So getting back to the pendulum, I hate to see that stuff. And are the therapists who are doing only manual therapy versus the therapists who are doing only strengthening? The patients, the therapists who do only strengthening are probably doing their patients a much better service, because in the end, manual therapy is transient, and the effects of strength training, as long as the patients are keeping up with it at home, and obviously they probably have a better understanding that they need to keep up with it at home, unless they're for some reason seeing the therapist like 4 to 5 times a week for like a couple of hours, they're probably better off in the long run. but yeah, what my fellowship mentee said, he was sitting like with someone like one of the grandmothers of our profession, like like a Florence Kendall or a Marilyn Moffat or someone who like a Shirley Sauerman, someone who just like
Right.
is exercise only, right? And she was just like basically grilling him, like, oh, what are you doing here? And he's like, oh yeah, I'm in a fellowship program. I don't know how I ended up sitting with her at some like APTA dinner or something. And he's like, oh, I'm fellowship training. I'm about to finish. She said, oh, manual therapy fellowship, huh? And she's like, I can do anything. She started asking about research and everything. And he was smart as a whip, this kid. Um, she said, well, I think you definitely know what you're talking about, but anything you do with manual therapy, I could do with movement and exercise. And he said, well, all due respect, ma'am, that's true, but I could do it faster. And that's the way that I look at manual therapy, right? Like there's just because it's non-specific and it's all placebo, which is what a lot of these people say online when they say like, oh yeah, I just gave it up because it's all placebo, or I never got results. And one to the never got results part, I always think if you never got results, then I don't know what you were doing because literally like a monkey who doesn't know what they're doing can get results. Like anyone can get results from manual therapy, and you don't have to be as specific as however you learn because none of us are. I mean, like we all learned from these gurus who said we have to use our pisiform and push in exact direction of the facet. None of us are actually doing that. Even if we were pushing the exact direction of the facet, we're not really moving the facet or realigning anything, but yet we still get results. And it's mostly because of belief in ourselves and also the patient believing that something else is going to go on, right? Like that would be placebo, the positive expectation that something is going to happen as a result of this interaction. But I mean, when I hear things like I just gave it up because it's all placebo, I just think, what are you going to do when someone walks in with like a huge lumbar lateral shift with neuroscience and they can't even fit when you're taking their history. It's not like you're just going to give them a kettlebell on the opposite side and hope they straighten up or get them to do deadlifts. I mean, I don't understand. Like in that case, there are only certain things that you can do to modulate their pain. Should you get them loading eventually? Yeah, but I mean, I don't understand. It's like, do they never treat these serious patients? Does everyone just benefit from strength training? I mean, they must not see the same type of serious spinal patients that I do.
Right.
So yeah, I mean, very few people who do manual therapy only, or pain science only, or strength training only. They're always going to have a limited amount of patients they can treat. And they're always going to run into walls, and the majority of people always run into walls, which is why they take kind of to begin with, right? It's like, oh, they're not good with neck patients, they're not good with TMJ patients, they're not good with knee patients, et cetera, et cetera. Or they're always looking for something to help a certain type of patient that they perceive they failed on. But there is no one course or any one technique or school of thought that's going to be able to, it's going to make you excellent at treating every single patient, because sometimes there are patients that you're not going to be able to reach. And that's, I think, one of the biggest lessons that I heard even early on in my career. One of the instructors I was learning from Greg Johnson from the Institute of Physical Arts, said he studied under like Maggie Knott, Margaret Rood, like the founders of PNF. And he just said that, when he was mentoring with them, they had like the worst experience. Patient was yelling at them, they didn't get better, something like that. Like it was just a terrible, terrible experience. He was like visibly shaken, and whoever he was training under, they just like walked out of the hospital room, composed themselves, like put under game face, and were like totally fine for the next patient. And he said the one thing I learned is that you can't take this stuff home with you, and we all tend to do that. It's like, oh, what could I have done better? What could maybe I should take these needling courses, or maybe I should take the soft tissue courses or neurodynamic courses, or I'm not good enough at pain science. Sometimes it's the patient and not you,
Right.
um, and
Well,
that's
yeah,
a hard
that's
thing to realize.
for sure. And I mean, we break it down, and whether you spend 20 minutes of one-on-one care or 90 minutes of one-on-one care with a particular patient, the vast majority of time they spent with you that week was not with you. So there's a lot of things
Yeah,
that
for
can
sure.
happen. And obviously we have yellow flags to consider in those cases, and a lot of other stuff. And home program things are super important just to get carryover. Sometimes making a small improvement and just focusing on maintaining that versus, well, now that we've done a little bit of this, I want you to do these 5 things, regardless of how you necessarily felt about them, can be more beneficial. And I know that, for me, definitely not with every patient, but giving people a motion guidance home pack, especially for ocular motor issues, balance issues, posture related conditioning with neuro based conditions like Parkinson's or something, they're going to need that repetitive input on a daily basis, and giving them the tools to have that, or at least the education to understand what is most important can be part of the breakthrough. So really more of a, hey, I need you to understand what we need to do different between sessions than necessarily everything that we do on this session.
Right.
Hopefully improving every time as the expectation. Yeah, there's there's a lot of great stuff in that little back and forth there too. It's really complex. It's disappointing to see that sometimes we get so polarized in our profession, and of course reimbursement keeps typically going down. So how have you been doing with cash-based approach? I'm sure some people, since you mentioned that, like want to know, some insights into cash-based PT, what you've experienced. Give me a quick hitter on your experience with that.
Well, I find that, for certain people, it's a tough sell because I'll get calls every week that say, "Do you take insurance?" Even though on my website, which they typically came from, it says I don't take insurance, and it says why I don't take insurance, because my visit average is 2 to 4, and I see people like once a week or once every other week, because I again make it all about the home program. It doesn't mean that I don't communicate with people right away, but I get to charge like 2 to 3 times or more what I get reimbursed typically. And I find that people are very happy to pay for it, because my typical patient is someone who's seen like a bunch of other PTs, chiros, massage therapists, or whatever, and they haven't gotten results, and that's fine whether they get results or not. They recognize that there's something different, and I find that I also don't have any trouble with adherence or compliance to home program, because they are paying me upfront even for the visit. It's not even like I charge after the visit. I charge on my website to even book a time, unless they book like the 15-minute kind of discovery phone call or visit, because that's free. So, there's that. And I think it makes PT for them as a commodity, like a massage or personal training, versus when it's like a $25 copay. It's like they don't often, they're like, oh, I'm just not going to do those exercises, or like people they like have no problem canceling or being 10 to 15 minutes late for us, which I used to get a lot when I was, in an HMO based clinic. But people they don't do that to the hairstylist ever. Like they're mortified if they do it to the hairstylist, because they see the hairstylist as a commodity and their time is valuable, versus like, for some reason, maybe because we're so friendly and everything too. And I used to have a secretary who would literally just let people in if they were 10 minutes early, one day early, they're not even here on the wrong day. Oh yeah, just go back and exercise. He'll get to you. I'm like, man, no, like no one just goes back like to the hairstylist,
Yeah, in
and
any
just starts like
office.
washing. Yeah. They start like in any office. They don't start like just washing their hair because they're early,
Yeah.
But for some reason, they like hop on the bike, and you're like, oh, you're like 20 minutes early. Like, oh, I just thought I'd hop on the bike. I'm like, the bike is actually part of your visit. It's not just like something I put you on because I don't have time for you, which kind of it is in a way, like air quotes. But I mean, that whatever exercise I have you do here is part of your visits. It's not just like because I can't be with you right at this minute, you know. So yeah, but I mean, I've been cash pay for a long time. I really enjoy it. Patients, again, it's a tough sell to some, but they're not my clients. My clients are the ones who have been around the block or not getting results, or just by word of mouth, they say you should go to this guy. But I'm out of network. Most people have out of network reimbursement. They get reimbursed instead of me by the insurance company. And again, I don't really have any problem with compliance. One, because I do, again, make it all on the patient. I gave a very, very specific program that I call a recovery plan. You can go ahead and steal that from me. You call it homework. The connotation is, I can even ask you, have you ever enjoyed doing homework, Eric?
Yes.
Right. Yeah, there's like a small percentage, maybe Eric. Eric seems like the type of super smart guy, nerd, that would actually enjoy when a teacher assigned him homework. But the connotation of homework is like, oh man, it's good for me. I have to do it. But did you ever enjoy it? Did you ever like feel motivated to do homework? I mean, I was always motivated to do homework as a kid so I could play video games later. But that's not real motivation to actually do the homework for learning's sake, right?
Right.
So a couple years ago, one of my patients called, he wrote me a Google review. It said, "Doctor, he gave me a recovery plan, and all I had to do was follow the steps of this plan. And after one visit, I was like 100% better." I was like, recovery plan? It's like, that's so much better. now when I give people a recovery plan, it's like the, the psychology of my website. Like, call me for your custom designed recovery plan to help you recover from whatever it is that's going on. No one wants homework, but a recovery plan sounds like something that, and it is something that patients are generally excited to follow.
Yeah, it's positive framing for sure. Like you mentioned
Yeah.
earlier, like, trying to make as much a positive influence as possible. I literally just had to cancel this week. That when I went to, it was on an initial evaluation, and when I went to complete the, the voiding appointment just to get it back off the schedule, the little note from the front office said, "Found a massager online, doesn't need PT." And so, so there's still a huge perception of like, okay, obviously that was not a personal referral, I hope,
No.
to me.
Right. Yeah.
But people are just out there to get what they need. So meeting them on an individual basis is going to be required. And if that's how people feel, I'm not necessarily going to try to change that, because I think all the research has shown that's belief changing is going to be a slow drip over time. So we're we're not trying to say, oh, you're wrong. This probably ties into very modern health issues across the world right now. I mean, trying to change somebody's belief on what they've heard or not heard is going to have to be a caring approach. It can't be a fear approach, and it definitely can't be so I'm going to change your mind today. It's going to have to be a gathering of information. But that's what we do every day as skilled clinicians so I'm going to give you some information, and hopefully that helps you make a choice, and maybe we can make that choice together. And I love the reframing of a recovery plan, because it's the same information that you would have given under the guise of homework, but very positive, and allows them to say, okay, so maybe I should think about this differently, not Dr. E telling me I need to think a certain way. So I love that.
Right.
So this is,
what,
great.
Actually, you said something else too that I wanted. Yeah. You said something else that I wanted to touch upon. Going back to like the whole, I do strength only, right?
Yeah.
Right. Or I'm evidence-based, which is why I don't use manual therapy. And I'm like, okay, well, if you're really evidence-based and you only do strength training, which is great, because again, strength training does, I say it does improve everything in a way, way more than manual therapy would. If you're really evidence-based, you're ignoring all the research that shows patient preference for a certain technique. Like if a patient had cervical manipulation in the past and they have a positive expectation and belief system that they improved from the manipulation, and it's not on the menu, then they're going to go to a different restaurant. It's like, that's why I say, like, again, an eclectic approach is best, because if someone said, like, if you have to convince someone that strength training is only for them, or manual therapy is only for them, or needling or whatever, you're already running an uphill battle. So I just liken everything to having like kind of like an American style restaurant instead of like going for Thai food. You go out for Thai food, but you only want like hamburgers, you're not going to get what you want, right? Like you should have more stuff on the menu, which is not to say that, and I totally get the toolbox versus the decision making argument, which is also always online. Like, don't just try to expand your toolbox, you should try to improve your clinical decision making. Well, you can actually have your cake and eat it too in this case, because you can have a good toolbox and you can have great clinical decision making, but it doesn't mean that just because you have good clinical decision making and you're evidence based doesn't mean you don't need more tools in the toolbox. Typically, you're going to run into a patient who's had success with motion guidance, or with needling, or with ISTM, or with McKenzie type repeated end range loading. And if you don't have it on them, again, if you don't have that to offer, they may go somewhere else.
Yeah. Oh, for sure. That can always be an interesting clinical discussion too, when someone comes in and they already have a set preference based on experience or a life experience,
or even a referral.
Yeah, exactly. Down the street. Exactly. They're like, well, I was told to come to you, or my doctor gave me a referral for this because they think it's going to help. You got to have some pretty stout evidence to not do that treatment for them, just even on the placebo gain that you might get on that first visit. You can always give them more information. And once again, though, I agree with you, that uphill battle is a tough one, and probably providing a negative experience on their first one if you try to tell them this is not going to work, because we really don't have the information on many treatments that says, hey, this is not going to work.
Right.
For
I would just say it all works. It's easier to say that it all works rather than this isn't going to work.
Yeah. Well, correct. And if your mindset is right, this is going back to part of our previous conversation. If my mindset is based on my diagnosis, I'm expecting some change, what they're requesting might get them some change. And I can easily say, if we're not seeing some change fairly quickly, I think we should try something different.
Right.
Because we're here together to do this, to notice some change that you're comfortable with, not to do this for the next 12 weeks and hope that we get somewhere. Part of that mutual decision-making process. Yeah, that's fantastic, man. We have touched on so many hot topics. I think we just destroyed maybe Twitter there for 30 minutes.
Right.
just blowing up a bunch of different myths and biases and all sorts of stuff. And I guess we could even probably finish it off with, hey, if you're a clinician just searching for more information out there, there's hope. You can be an excellent clinician and not have to buy into a dogma, not have to buy into a person with 70,000 followers on an Instagram page.
Nothing wrong with that, though.
Nothing wrong with that.
Just so you
can make some differences.
I mean,
you can
some
make
of
some
us
differences.
earn our followers. I actually only have half of that. I have 75 on 75,000 on Facebook. 30.
Oh, I didn't even know that.
Yeah, 35,000 on Instagram. And like 10,000 on Twitter.
Yeah.
But yeah, over 100,000 when I combine everything.
There you go. Like you said,
I
worked
for it though. I worked for it.
I can vouch for that for sure. Dr. E is dedicated to the profession and to just making people better. So, well, this has been great. Thank you so much for coming on this little Zoom cast here. This is invaluable information, I feel like. How about one last time you hit us with where you can pick up motion guidance through your resources, and then also what your social media handles are?
Sure. I'm at Modern Manual Therapy on Facebook, Instagram, and YouTube. You can also find me on LinkedIn, Erson Religioso. I don't think my dad's on there. Modern Manual Therapy, the Eclectic Approach are my seminars. If you go to theeclecticapproach.com or just go to edgemobilitysystem.com, all my seminars and all my products are on there as well. And again, my seminars are my live seminars. I'm starting to kick back up this year. I basically canceled almost every single one of them in the past couple of years. I taught 4 last year, but they weren't closed. They were all closed to the public. They're all like corporate based. So I'm starting to have open courses again this year. If you join my mailing list on the manualtherapist.com, which is my old school blog, it's my old school blog that kind of first launched me on social media and got me known by a lot of great clinicians like Eric. Join my email lists there, and we get notified of any of my live courses. And you can also do the same thing on edgemobilitysystem.com. Just Google me, Modern Manual Therapy, and you'll find a ton of things to follow because I have a lot of stuff. So.
All right, great. Thank you very much, everybody. This has been Dr. E and Eric from Motion Guidance, and we will see you soon. Don't forget to go to motionguidance.com for more information on talks that we have coming up, other special topics, as well as our continuing online education forum, and look for our live courses and our products. Take care, guys.